Good afternoon, everyone. It's 12:15 on my watch, so I think we can start. I have the pleasure to introduce two speakers today who will share the grand rounds. The topic is one of our big challenges in pediatric cardiology, which is the single ventricle patient. In particular, there will be conversation about the circulation in the single ventricle patients after Fontan procedure, with some of the complications related to the Fontan procedure, and these specifically complications of the lymphatic system. Dr. Lazaros Kochilas, who is one of the pediatric cardiologists and associate professor in pediatric cardiology, will be the first presenter, followed by Dr. Siobhan Flanagan, who is an assistant professor in radiology. And I was asked by the presenters to keep the introductions short because they have a lot of material to cover. So I will just remind briefly to everyone that Dr. Kochilas has been in our division for 7 years and has had numerous interests besides clinical interest in the research arena, primarily outcomes research, but also different physiologic setups, and one of them is the Fontan physiology, the single ventricle physiology. So he will discuss mostly the abnormalities and the diagnostics, and Dr. Flanagan will help us with some of the imaging in these situations and in possible interventions to improve the lymphatic circulations. So I will give the podium to Dr. Kochilas to start with.
Thank you. I shouldn't need that, huh? Can you hear me from the other microphone? Sure. All right, let's try again. Is that better? Much better, eh? All right, and I hope this one is working. Okay. All right, so I wanted to talk today about the forgotten circulation congenital heart diseases. And I don't want to keep you in mystery. It's about the lymphatic circulation, which is something that we don't talk very frequently in pediatric cardiology and in any cardiology. And we tend to forget about that it's a very integral part of the whole circulatory system that we have. Now, in this presentation, both me and... So how is this one is working? It's not a simple click. Oh, it's on. Well, I can use the mouse, I guess. All right. All right. So in this presentation, I will co-present with Dr. Flanagan from the Division of Radiology, and we have no financial disclosures. However, some of the things that we will discuss, they're off-label use and investigational use items that have not all of them approved for the indications that we use them. So I wanted first of all to give some of the highlights in the history of the lymphatic system, going back to the very early years when one of my compatriots, Hippocrates, he did the first description of the axillary lymph nodes and the white blood that is circulating in these nodes. And he didn't call them lymph nodes, and nobody actually called them as such until much, much later, as you will see. And then Aristotle, he described the fibers that are running between blood vessels and nerves. And again, he noted that they contain colorless liquid. And we have thereafter multiple references on mesenteric lymph nodes between 300 BC and 1562. And at that time, Eustathius is the first one who describes the thoracic duct and gives the name vena alba thoracica because of the white matter that was circulating within this structure. And it's only about 100 years later when Bartholin, for the first time, uses the word lymphatic, which is a paraphrasing of the Greek word nymph, which means clear, colorless fluid. And a little bit later, William Hunter, he will put the statement out that the lymphatic vessels constitute one great and general system. And much later, Starling discovered that the lymphatics do absorb protein from the tissues and return it back to the circulation. Later on, between the 1950s and 1960s, there is a lot of activity in developing clinically applicable indirect and direct methods of lymphangiography. But most of the interest about the lymphatic circulation is mostly related to cancer dissemination and treatment. And now I want to present some material that may make us change our mind about what's the interest of pediatric cardiologists to know about lymphatic circulation. Right, well. I'm not sure why none of the methods work to advance the slides. Oh. Does? Okay, all right. Sorry about that. Here I do have a brief description of the development of the mammalian lymphatic vasculature, and I don't want to go through all these molecular events, but I want to talk a little bit about the stage E, which is way after the initial differentiation between venous and arterial vessels and subsequent induction of the so-called lymphatic endothelial cells. The event that is very interesting for the functionality of the lymphatic system is what it happens at the stage E, where these lymphatic endothelial cells start expressing a protein that's called proteoplanin, and this activates the platelet aggregation factor via the CLEC2 tyrosine kinase system. And this activation initiates the formation of a platelet aggregation at this spot here, which is the origin of the primary lymphatic sacs from the venous system. And by forming this platelet aggregation and thrombus, you initiate the separation of the blood from the lymphatic vascular system. And that it happens only in the one end of the lymphatic circulation, while at the other end, the subsequent differentiation events, they will lead to the development of a valvular system that allows lymph to go back into the central venous circulation without risk of forming a local clot. And that's a key event, not only to understand the functionality, origin of the lymphatic system, but also to understand some of the complications that we're facing in lymphatic circulation impairment, and can give us some hints about what we can use to therapeutically solve some of these issues. And a little bit more information about the CLEC2. It's a platelet activation receptor, contributes to clot stabilization until flow condition, and inactivation of the CLEC2 prevents thrombus formation without significantly increasing bleeding diathesis. So it is a very important therapeutic target for the pharmacological industry, that they want to prepare products that they are helpful to prevent clots and at the same time have very little risk for bleeding. In other words, this is the holy grail of the control of the hemostasis. Now, some think that it is important to differentiate between the blood and the lymphatic circulations. They're being summarized here. And in mammals, we know that blood and lymphatic vessels that do play an essential complementary role that require different structures and different function. We know that the big difference, we already said, the blood is red and the lymph is white or colorless. And blood is transported also with a high pressure closed vascular network in which the flow is driven by a pressure gradient that is generated by an active pump, which is the heart. On the other end, the lymphatic system regulates tissue fluid homeostasis, immune cell trafficking, and absorption of dietary fats. The lymph is acquired from the tissues from a low-pressure, open, permeable vascular network in which the flow is maintained by contraction of the collecting vessel walls, by external compression, and by valves that allow the flow to move to one direction. Now, lymphatic and blood networks, they do connect at the lymphovenous junction, where, as I was hinting at the beginning, there is a leaflet. In fact, it's a bileaflet valve at this junction, and the purpose of this leaflet, of this valve, is to prevent the backflow of blood into lymphatic vessels. The reason why that is important is because the lymph cells, they do have these activated CLEC2 receptors, and when they come into contact with the blood, then a clot is being formed. And this is a diagrammatic representation of the general plan of the lymphatic system, how the lymph is collected from different parts of the body, starting from the lower limbs, and then with contribution from the splanchnic circulation, they form the cisterna chyli, and then they do form the thoracic duct that goes up into the chest, and eventually we're going to turn around and drain into the left veno-lymphatic angle, which is where the internal jugular vein with the left subclavian, they come together. This activity is mostly happening on the left side of the body, and there is a smaller lymphatic draining system that's coming from the right side, and the end result of that is the formation of a right lymphatic duct that comes into the right side of the central venous system. And this is the peculiarity about how the thoracic duct at the beginning in the abdomen is being formed into the right side of the body and then turns below the esophagus to become a left-sided structure when it enters the chest. And these are important implications for the radiologic approach to the thoracic duct and how we can get access to this system. Now, there are multiple variations. The most common, of course, is the single left thoracic duct that enters the thorax from the right side of the aorta and then crossing to the left at about the T5 level to eventually drain into the left venous system in about 60 to 65% of people. Sometimes there's a partially duplicated thoracic duct that's draining in the left venous system. Sometimes there is a double thoracic duct throughout its entire course and opens into the venous system on the corresponding side. Rarely there is only a right thoracic duct that drains in the right venous system. And also quite rarely there is the variation that there is only a left thoracic duct in its entire length up to the drainage point in the left venous system. And this is the pattern of drainage from the lymphatic circulation. And very diagrammatically, you can see that most of the body fluid is collected by lymphatic vessels that eventually they will going to drain with the left main thoracic duct into the left venous system. And on the other side, the half of the face and the right upper part of the chest will going to drain with the right thoracic duct into the right central venous angle. And then in the diagrammatic presentation at the left side of the slide, you can see the different contributors in the abdominal, in the splanchnic circulation that they do come, from the kidneys, from the stomach, from the liver. They feed the cisterna chyli before the thoracic duct is formed and enters the chest cavity. Now, about 40 years ago, there was a cardiologist who actually was very interested in the lymphatic circulation congestive heart failure, and he published a study that would be very difficult to replicate in today's environment, where he wanted to describe the effect of the congestive heart failure into the lymphatic circulation. And very simplistically, he described that the circulatory system is divided into the peripheral vascular bed and the splanchnic bed. And he described the situation that when a patient has a heart failure, then you have a lot of body fluid and tissue edema that it feeds and being absorbed by the lymphatics, goes back to the thoracic duct, and the thoracic duct is kind of congested and dilated in high pressure, as it is very commonly the case in patients with advanced heart failure. And then he compared that with what is happening in patients who have hepatic cirrhosis. And in this case, you don't have total fluid overload, but what you have an outflow obstruction of the splenic lymphatic circulation. And as an exit, it finds the collection of this increased amount of fluid into the abdominal part of the lymphatic system. It contributes to ascites and contributes to a congested thoracic duct as well. He also did a very systematic approach, and he studied control patients. He studied patients with compensated heart failure and patients with decompensated heart failure by cannulating the central location of the thoracic duct and measuring the mean flow of the lymph, the pressure, and the total protein content. I'm not sure how he managed to get control patients for doing this study, but he did, and the results were actually very impressive. So as you can see, with the black column are the patients who have decompensated congestive heart failure, and they have about 4 times more lymphatic flow than the patients who have heart failure but is compensated, or the control patients. Similar with the pressure is much higher in the patients with decompensated heart failure, and in the matter of content of protein, it's kind of the opposite effect. In the patients with decompensated heart failure, there is less protein because you have more dilution, because more fluid, more water is available to dilute the available protein. Now, how all this now will be relevant for the patients that they have a single ventricle physiology, which most of the time means for the long-term survival of these patients that they have to be on a form of cardiopulmonary anastomosis. And we have 2 forms of cardiopulmonary anastomosis. We have the superior cardiopulmonary anastomosis, or the so-called Glenn procedure, and where the SVC drains directly to the pulmonary circulation. And we do have the total cardiopulmonary anastomosis, where both the IVC and the superior vena cava, they bypass completely the heart and they drain directly into the pulmonary circulation. So basically, the principle of this palliation is to put the systemic and the pulmonary circulation in series and having the whole circulation driven by a single ventricle. Now, this is a big challenge to the principles that William Harvey has taught us many, many years ago, where he described that in whatsoever creature there is lungs, he is expected to find 2 ventricles of the heart, one right and one left. So this challenge, we're going to see what kind of implications may have for the circulation. Now, the magnitude of the problem of the single ventricle palliation is actually quite significant, because Fontaine in the recent years has become the most common surgical procedure for children with congenital heart disease above 2 years of age. And for example, I can mention that in the registry that we have at the Pediatric Cardiac Care Consortium, there are registered almost 13,000 patients with Glenn and Fontaine procedures between 1982 and 2007, which makes it one of the most common procedures for pediatric cardiology. In the registry of the STS and the European Surgical Society, there are 5,600 Fontaine procedures only between 2007 and 2010. Now, these patients, as William Harvey had predicted that this was not going to be an easy task, they have a lot of chronic complications, and these include conditions that are frequently associated with impaired lymphatic circulation, and more importantly, the two of them is the plastic bronchitis and the protein-losing enteropathy. Now, what is the pathophysiology of these lymphatic impairments in the cardiopulmonary anastomosis? It's kind of interesting because this circulatory pattern basically combines elements of both congestive heart failure and hepatic cirrhosis. At the stage of the gland, we just have the increased central venous pressure, but still the IVC, it allows to drain directly into the heart, so it is protected from this high pressure, and we do have increased resistance only to the lymphatic drainage at the central venous angle. In the Fontan circulation, that we have both IVC and SVC draining in the pulmonary circulation, we have both increase in the central venous pressure and in the IVC pressure. And this causes both increased resistance to lymph draining, but also increased lymph production because you have congestion of the liver. On top of that, exposure to multiple surgeries may be an additional factor for local inflammation at the lymphovenous junction and may be another precipitating factor to cause obstruction at the valve that allows the lymph to drain into the vein. With chronicity, eventually this liver congestion leads to development of liver fibrosis, and now you have the component of splanchnic flow obstruction that you have in liver cirrhosis that I described before. And in short, the Fontan circulation combines both risk elements for lymphatic circulation abnormalities that were detected like 30 and 40 years ago. What do we know about lymphatic circulation in Fontan patients? Well, we know that dilated lymphatics are very common in these patients. We do know that lymphangiectasia is commonly found in patients who have protein-losing enteropathy. We have found chylous bronchial casts in patients that have plastic bronchitis on the background of Fontan circulation. And more recently, we found lymph leakage into the bronchi and retrograde flow into the peribronchial and pulmonary lymph system in Fontan patients with plastic bronchitis. And in the pictures, you can see a microscopy slide from a patient with PLE that has dilation of the lymphatic vessels, and on the other side you can see a bronchial cast, which is this proteinaceous material that basically forms a cast of the bronchial system, and it is very, very difficult to mobilize unless you do a rigid bronchoscopy, and with powerful suction you can have it out, otherwise the patient will get suffocated. So we put together a hypothesis that the systematic evaluation of the lymphatic circulation and the thoracic duct may be useful in a few things. May be useful in monitoring the status of the lymphatic circulation in conditions where impaired circulation is expected. It may help to identify specific patterns of thoracic duct drainage abnormalities, but more importantly, it may guide some therapeutic interventions when impaired lymphatic circulation is suspected to be involved in clinical scenarios. The ultimate goal would be to explore the potential of non-invasive imaging, ultrasound and MRI for thoracic duct abnormalities in patients with suspected impaired lymphatic circulation, identify patients where interventional imaging is required, and design and implement intervention strategies to address complications of impaired lymphatic circulation. We started with ultrasound. That is the tool that we as cardiologists will have more easily available and we understand more than anything else. And to give you a little bit of background, in cardiovascular conditions that there is increased CVP, that leads to impaired lymphatic drainage and thoracic duct dilation. We know that. We know that complications of plastic bronchitis and PLE are associated with lymphatic drainage abnormalities. However, it is not known the feasibility of assessing the cervical segment of the thoracic duct during echocardiographic evaluation in children with various conditions. We also don't know the patterns of the thoracic duct size and flow in patients who have congenital heart diseases. So we used some guidance from the adult literature that they have studied the drainage of the terminal part of the thoracic duct into the left venous ankle. That is diagrammatically presented here at the junction of the internal jugular vein with the left subclavian. And if you put a transducer along these three different axes, you can get actually very informative information about the status of the thoracic duct drainage in the venous system. And I will try to show you some examples from here. I hope that these things will work. So this is a normal patient, and you can see here a junction of the left internal jugular and the left subclavian. And the thoracic duct, in this case, has two separate channels, which is a normal variation. And in fact, it's kind of easy to see the thoracic duct drainage because the lymph content with the lymphocytes and the lipids, it's actually echo bright and gives you this automatic contrast signal. And you can easily differentiate the venous than the lymphatic structure because of this contrast that you have. Now, in the next one, I will show you same kind of picture, but in an 18-year-old boy who has a protein-losing enteropathy and the status post a Glenn procedure. And you can see now the valve, how it opens and allows this rich content of the lymphatic duct to drain into the vein circulation. This is from the same patient, a little bit of a different view, where you can see the valve a little bit better than in the previous. And then here we have the same patient who eventually needed to undergo heart transplant because of ongoing and severe PLE. And then he experienced acute rejection, so he had a very high central venous pressure. And you can see this very dilated, tortuous part of the posterior part of the duct that is going around and forms an arch before it straightens out, leads to the valve, and then drains into the central venous circulation. When we used the Doppler, the color Doppler, which shows directionality of the flow, and the blue is the direction that's going away from our transducer, and the red is when the flow is going towards the transducer. You can see that this is a case that you have regurgitation of the lymph flow from the venous circulation back into the lymphatic duct, which, as I told you before, this is a condition that if it persists for a long time, eventually will lead to clot formation. And this is a static picture from the spectral Doppler that basically shows the same thing, the bidirectionality of flow into the lymphatic drainage of this patient with severe heart failure and very high central venous pressure. We experimented also with different transducers, and thanks to Jim Berry, who has a lot of expertise in studying everything with ultrasound, we're able to get high resolution. Here the labeling is a little bit off. The left internal jugular vein is here, and the thoracic duct is here. But we're able now to have a very nice, clear picture with a high-frequency transducer of the drainage of the thoracic duct. And we can see better the flow by putting the appropriate location of the probe. And we noted several interesting things. For example, that the lymphatic flow has a continuous low flow velocity antegrade. There is some reversal of flow that is normal during expiration, and that this flow pattern in the thoracic duct not always correlates with the cardiac cycle. And that's probably because of the independent tonicity of the lymphatic vessels themselves. So what we learned from this exercise was, first of all, that the ultrasound imaging of the terminal segment of the thoracic duct is feasible, even in very young children. In fact, my colleague, Shanti, she has even been able to see that in fetuses. There is a tremendous variability in the size and the pattern of the terminal thoracic duct. In patients more than 5 years old that have Fontan or congestive heart failure, our imaging success rate was about 60%. We found frequent lymphatic abnormalities in patients with congestive heart failure, PLE, and plastic bronchitis. But more importantly, we're able to find two distinct patterns. Patients with PLE and congestive heart failure had a very dilated thoracic duct, while patients with plastic bronchitis, frequently they had an obstructed thoracic duct. Regurgitant flow in the thoracic duct was observed physiologically during expiration, but very pronounced in cases with severe congestive heart failure and elevated central venous pressure. So ultrasound is an easy, non-invasive first step to study lymphatic drainage abnormalities, and we believe that based on that, we can use it as a screening tool to identify candidates for invasive lymphatic imaging prior to considering therapeutic interventions. And at this point, I would like to have Dr. Flanagan guide us of what we can do from diagnostic and interventional procedures for the lymphatic circulation.
Do you have time for questions now, or you want to wait?
It's better in the end.
Okay. And we're done at 1, is that right?
1:15.
1:15, okay.
Yeah.
So once it's been determined, well, a patient has a diagnosis of plastic bronchitis, how to take care of this or potentially identify a location for treatment requires some imaging workup. From a clinical standpoint, a bronchoscopy is helpful in identifying the distribution of casts in addition to the therapy that can be done, extracting those casts at the time. Airways that are identified as having quite a few secretions or casts in them, the thinking is that the site of leakage into those airways is in that vicinity. A chest CT can be very helpful in the same manner in that we can also identify bronchial casts on chest CT, but also when the deposition is so severe, you're going to see some alveolar deposition of this material, and that manifests as ground glass densities or even dense consolidation on a chest CT. And then moving more specifically to lymphatic studies, some non-invasive ways to look at the lymphatic drainage would be by MR lymph angiogram, which has really become the preferred method for assessing the lymphatic ducts, but also a fallback study that's still available to us and still useful from time to time is nuclear medicine lymphoscintigraphy. So we'll go through the imaging sequences of MR lymph angiography. There are two critical sequences that really give us a lot of information. A non-contrast T2-weighted imaging series. It's a fluid-sensitive sequence, and that looks bright on MR images. Fluid looks bright. I'll show you some examples of that later. But what it does is it shows us the distribution of normal and abnormal appearing lymphatic ducts, and it can find these dilated lymphatic ducts and also areas of duct proliferation, which tends to happen toward the lung that has the site of leakage. Then there's a dynamic contrast MR lymph angiogram that we do, and that will that's a more dynamic imaging series that shows us the pattern of flow, but can also identify aberrant channels and the exact location of leakage into airways, which is ideally what we would find to guide further management. So here's some examples of the MRI, the T2 weighted images. This top image on the left is what the normal lymphatic duct should appear like. The thoracic duct should be relatively narrow in caliber, but visible. Without a visualization of side branches from that duct. In a patient with cirrhosis, like Dr. Kochilas had mentioned, there's a dilated thoracic duct, and then if you look at the normal image on the top left and you compare that to the abnormal image in the cirrhotic patient on the left, you can see that there's all sorts of abnormal channels and kind of laking and pooling of lymph as it's searching for some pathway back to its destination. So again, cirrhotics have develop ascites in this scenario. And on the right-hand side is a patient with plastic bronchitis, and you can identify the lymphatic duct, which doesn't appear as dilated in the lower left-hand image in the cirrhotic patient. This is a 3D rendered image you can see that there are some proliferative ducts in the abdomen, but you also notice them up in the right subclavian region on the left as well. So these are areas of proliferation. Here's another example of one of those non-contrast T2-weighted images that has in another Fontan patient that shows a bunch of proliferative ducts along both airways, more so on the right, and also a 3D volume rendered image that just places these dilated aberrant ducts, or proliferative ducts in the region of both airways. You can get a sense of where they're arranged, and you might find your focus of leakage on your contrast images. So looking at the lymphatic abnormalities in patients with protein-losing enteropathy and plastic bronchitis, again, lymphatic abnormalities are common in both these patient groups. The patients with the protein-losing enteropathy tend to have the dilated thoracic duct, and the patient with the plastic bronchitis tends to have these proliferative ducts in a parabronchial location. Again, that's demonstrated in the bottom set of images here. T2 bright proliferative ducts that just look abnormal and disorganized. So our dynamic contrast MR lymphangiogram is performed after we do an ultrasound-guided puncture of an inguinal lymph node with a small angiocath. After that's placed, we put the position the patient on the MR scanner, and we do a slow hand injection of 2 cc's of gadolinium into each of those lymph nodes, and then we start acquiring these T1-weighted images over 10 minutes. We start imaging quickly after the contrast, within a minute after the contrast administered, and then we continue to acquire images every 30 seconds, and we'll continue to image until we see as much as we expect to see on the MRI. So this is a series of contrast images, post-contrast images, that identified a lymphatic leakage via an aberrant duct in a patient with plastic bronchitis. You can see in the earlier images that contrast is in a prominent lymphatic channel here adjacent to the thoracic duct, and as time goes by, you can start to see that there's more and more contrast collecting in a parabronchial location adjacent to both main stem bronchi. And in this bottom hand image, you can see that there's one duct, or I can see that there's a duct that's contiguous and eventually leads or progresses toward the right main stem bronchus. And here's an anatomic depiction laying out that finding that near the cisterna chyli, there's this aberrant duct with, as we proceed through these various stages of post-contrast imaging, that the lymph is flowing through this aberrant duct ultimately toward the right main stem bronchus. So this was suspected as being the site of leakage. So lymphoscintigraphy in our nuclear medicine department still has a role. This primarily can be very useful in patients who can't undergo an MR lymphangiogram for a number of reasons. We often cannot image patients who have a lot of mediastinal or adjacent to mediastinal coils. That causes quite a bit of artifact that makes the MR images not interpretable. But so there's a technetium-99 tagged serum albumin that gets injected intradermally into the patient, and the patient is imaged over time in a planar images, and I'll show you those later. Those are acquired over time, and then eventually, if a site of leakage is identified in the lung, we can do a SPECT CT to hopefully localize or give us an idea of where that leakage is occurring. And you can't necessarily identify the exact point of leakage using SPECT CT, but you can at least get an idea of where the leakage does occur. So these are what planar nuclear medicine images look like, and this is a patient who is injected in both lower extremities, and over 10 minutes time you can see the radiotracer starting to accumulate in the lower abdomen, and you also see over time that there's a large deposition of radiotracer in a big cavity, which happened to be the left hemithorax. So we knew the leakage was into the left hemithorax, and when you see the accumulation at a level where there is not radiotracer deposited higher, you know that you're targeting at or below that level somewhere in the hemithorax for your site of leakage. So it's giving you kind of a generalized area, but still it's better than not having any sort of knowledge and fishing around through the whole hemithorax trying to find a site of leakage. And this is just an example of a SPECT CT image with the radiotracer that's identified in the left retroperitoneum here, posterior mediastinum, and you can see it pooling in that left hemithorax there. So for treatment options, we're contacted for percutaneous treatments, and the group at the Children's Hospital of Philadelphia and University of Pennsylvania have done an excellent job communicating some preliminary results of their thoracic duct embolization, but which eventually gravitated toward trying to do more selective embolization of different ducts because there's complications that you can have from thoracic duct embolization, like protein losing enteropathy. So selective lymphatic embolization of one of those aberrant ducts or thoracic duct embolization is an option. Percutaneous lymphovenous junction stenting is a technique that's not well described or not widely described, but it's been used in Europe from time to time in patients. The big question is the longevity of the patency of that stent. Surgical thoracic duct ligation is an option for patients who can't undergo embolization either because you can't find an aberrant duct to embolize, or perhaps they've had their thoracic duct embolized, and now that's about as far as we can go with our treatment. Once the thoracic duct is embolized, to reach any other duct is not possible from that point. Surgical thoracic duct duct decompression, which is another technique, and I'll show you a few images of that later, is also an option for patients. So for a percutaneous lymphangiogram with embolization, we do another ultrasound guided lymph node puncture, inject contrast, and then as time goes by, we're taking spot fluoroscopic images of the abdomen to identify the flow or pattern of lymphatic drainage. And ultimately, in most patients, you can opacify the cisterna chyli, which is a large enough structure that you can puncture and put catheters into for treatment. And ideally, if you identify an aberrant duct, you can use a microcatheter system to get into that duct after you puncture the cisterna chyli, take some preparatory images, and hopefully embolize that aberrant duct. And different agents that can be used for embolization is Lipiodol, and that's been used by the Philadelphia group, but also glue and coils. So these are a few images from one of the papers out of CHOP of a patient who did undergo lymphangiogram and did have an aberrant duct that they were able to fill with contrast. This is a catheter engaging the cisterna chyli, and the contrast is being deposited out of that catheter, and over time you can see that this aberrant duct was visualized. And there's a few pictures later where I can show you a movie example of what that looks like. They did identify that lymphatic fistula in the Fontan patient with plastic bronchitis, and this small line here is a microcatheter through which Lipiodol was injected, and that successfully occluded that aberrant duct, and the patient's symptoms improved. So again, the ideal embolization is a selective embolization of an aberrant duct, which leads to the network that drains into that adjacent bronchus or airway. And then thoracic duct embolization is not performed unless you can't find that culprit aberrant duct. And again, you can have complications from thoracic duct embolization, such as protein-losing enteropathy. So it's not the preferred method to start with, but when you don't have an aberrant duct to identify and embolize, then you're looking at having to embolize the thoracic duct. So the advantages of the selective embolization are, again, you maintain the patency of the thoracic duct. Therefore, the thoracic duct is patent to proceed with future interventions, because these patients, we are finding, do tend to reform a different aberrant channel to that lung eventually. So the targeted treatment of only the pathologic lymphatic vessel can improve the outcome just from the standpoint that you can go back in to later embolize and they won't have the complication of protein-losing enteropathy. So an alternative surgical method is a decompression of the thoracic duct. That high-pressure system on the right can be bypassed by dissecting the innominate vein or transecting the innominate vein and relocating that to the left atrium. So you're bypassing that high pressure. And here's some venographic images of that example. So here's the right innominate or right superior vena cava, pulmonary arteries. You can see the stump of that left innominate vein, and that has been attached to the left atrium. So this is a patient that we saw here multiple times, a 12-year-old with a Fontan who had developed plastic bronchitis. Her clinical presentation was pretty dramatic, acute onset of dyspnea and hypoxia. The unusual thing about her is that her hemodynamics for her Fontan were good, meaning that there wasn't that expected resistance to lymphatic drainage from the thoracic duct into the left subclavian vein. She had a lymphoscintigraphy that was negative for lymph leakage into her bronchi, and she just kept developing recurrent casts despite the supportive therapy. So she had an ultrasound done that had shown an obstructed thoracic duct. These are movies. And that was confirmed on lymphangiography. And on the lymphangiogram here, you can see that she has a slightly dilated thoracic duct and then quite a few aberrant ducts. For some reason, this isn't letting me play that movie. Oh, here it is. So all of these are those just ectatic proliferative ducts that tend to be formed in this high pressure situation in the lymphatic channels. And there's a volume rendering, 3D volume rendering of that MRI here. Dilated duct and multiple channels that are proliferative ducts. So she came to us for the thoracic duct embolization. Again, since her problem wasn't pressure in her central venous system that needed to be corrected, we had to look at her underlying problem. On her MRI, she did not have one of those aberrant ducts, but she did have, again, all of these proliferative ducts, which you can see from an obstruction at any point. So she underwent a thoracic duct embolization. We punctured the cisterna chyli, guided our microcatheter up the thoracic duct just below that junction with her subclavian vein, and then deposited coils and glue. And she actually was successfully closed on follow-up, and unfortunately, her casts returned 8 months later. We went ahead for a catheter lymphangiogram because of the coils. She couldn't undergo MRI. They caused too much artifact. And after the lymphangiogram showed that thoracic duct was successfully closed, her only option was surgery. So she underwent that subdiaphragmatic ligation by her surgical colleagues, and she's been asymptomatic since and then it's been about 4 months since she underwent that procedure. And a second patient with a similar disease, just obstruction right at that junction of her thoracic duct and left subclavian vein, underwent the same ligation and has remained symptom-free for about 7 months now. So our therapeutic interventions, did you want to pick up at this time? Okay. What a cardiologist begins with is optimizing the single ventricle physiology with the aim to lower the central venous pressure. Supportive therapy, bronchoscopy with cast removal, and there's also some medical options for helping mobilize those casts. Decreasing lymphatic production through diet and octreotide, establishing the patency of the thoracic duct if obstructed, whether it be by stenting, again, which is a less proven method versus a surgical option, eliminating lymphatic fistulas if present with lymphangiography and embolization, occluding the thoracic ducts in patients with plastic bronchitis, but good hemodynamics if patency can't be established or maintained, decompressing the Fontan circulation with a fenestration, translocating thoracic duct in patients who have a patent thoracic duct, and targeted pharmacologic manipulations, which include antiplatelet agents and VEGF modifiers, and benefiting the patients with other supportive treatments like exercise protocols and, again, a low-fat diet. And ultimately, in patients with poor hemodynamics, heart transplantation is the next step when all other measures have failed. So studying the lymphatic circulation has offered new insights into the pathophysiology of the Fontan circulation, and data from other institutions suggests that the lymphatic circulation is relevant, and there's two main chronic complications, plastic bronchitis and protein-losing enteropathy. And the Fontan complications don't necessarily mean a failing Fontan. It's not always an elevated central venous pressure that's the root of the problem. So decongesting and rerouting the lymphatic circulation offers a new paradigm in treating these complications, and it may defer or postpone the need for heart transplantation. And central lymphatic insufficiency possibly has a role in other post-surgical complications, such as non-mobilizable in postoperative patients and critically ill neonates. End.
All right, thank you. So there was one more thing, because I wanted to thank all of the people who have helped with that. It was Jim Berry. He was somewhere around. I don't see him anymore. He helped us a lot with imaging with ultrasound, the thoracic duct in these children. Chuck Shepard, who promised to move this project to the next stage and do a systematic evaluation of the thoracic duct drainage by ultrasound in children with congenital heart disease, without congenital heart disease, with surgery, without surgery. David Hunter from Interventional Radiology, who initially connected me with Dr. Flanagan, and we started investing into this strategy and how we will make it working. Alvin Chin, my mentor from the University of Pennsylvania, who suggested to me that I should think about how the lymphatic circulation may be important in the context of Fontan. Max Hitkin is the pioneer invasive radiologist at Penn, who actually opened a lot of new avenues for interventions for thoracic duct abnormalities. And Yoff Dory, who actually has a local connection with the University of Minnesota, he has been graduating from the School of Chemical Engineers here at the university, and then he decided that was not enough for him. He did medical school and pediatric radiology. He is the link to the interventional radiology program at the University of Pennsylvania. Thank you all, and if you have any questions, we'll be happy to answer them.
What effect?
It's coming.
Very nice. Is it on?
You can try this one.
I got two of them.
Two of them. Oh, that's stereo.
So I got to ask two questions. Very nicely done. My question is, what is the effect of the surgery just going into the chest on the normal lymphatic anatomy? And does that affect the abnormalities that you've described? And if not, what happens if you were to do a sham operation, just go into the chest and close it? How long does it take the lymphatics to recover, or do they ever recover?
Well, who wouldn't do a sham operation for that? But the project that Chuck Shepard actually intends to do, and he started with that, is actually to answer exactly that. So we want to examine children who have heart disease and children who don't have heart disease. And the children who have heart disease, some of them, they get operation, some they don't get operation. So by studying them, we hope we can separate how much is because of the opening of the chest and the inflammation that you create locally versus abnormal physiology. So that's exactly the point, because I think opening the chest may have some implications for the area and cause local fibrosis and perhaps obstruction.
Thanks.
I think there was somebody from the back that, oh.
So a question
Here.
up front.
There is a question up front.
Raise your hand. Thank you.
Thank you.
So Lazarus, that was a great presentation. My question is basically a single ventricle physiology patient has a very different physiological changes that goes on, plus on top of multiple surgical intervention. We haven't changed the concept of physiology, but we are trying to go after things that had happened. Is there any type of research going on to even change the physiology in such a way that we don't know if this is a central venous filling pressure problem or did we damage the lymphatics? What is it? We are going after things that we have created a problem, but ultimately we didn't have solved the issue of what do we do with these kids?
Well, yeah, as you noticed, and I mentioned that it's very difficult to challenge William Harvey. So he knew that we will get into trouble. Now we have to understand where is the problem, and my impression from this limited amount of information that we presented today is that in the Fontan patients we may have two sorts of problems. One is the increased production of the lymphatic flow because of the congestion of the circulation, but also some of them, they may have obstruction of the thoracic duct. And obstruction, I think it's happening because when you have increased central venous pressure, eventually you may have even short-lived backflow of blood into the lymphatic vessels. And as I said, when that happens, the interaction of lymphocytes with platelets, with the activation of the CLEC2 factor is thrombogenic. So once you start having, for example, in the acute postoperative period where you change the physiology and you start having this interaction, gradually you form clots and fibrosis, and eventually that limits the drainage of the lymphatic circulation. This particular patient that we presented here, the first one, has as good as Fontan hemodynamics as you can imagine. Had a Fontan pressure of like 9. I mean, it could be like a normal person. And that's why I think it's important to try to understand what's going on there, because this patient may not be successfully treated by heart transplant, but may be successfully treated by relieving this obstruction. Now, ultimately, you're asking about if we think along the lines of the problems that we have created with the single ventricle palliation model. As you know, the progress in pediatric cardiology, it doesn't occur slowly. It occurs with big jumps. So somebody has an idea, has a concept, and the concept is being put to practice. And when that happens, then you have a big jump. Then you go into a period of time that you stagnate and you try to solve the problems, and at some point you plateau. And then you need to have a new concept, and then you move forward. So at this point, I think we're trying to overcome the plateau of the stagnation of the outcomes of patients with Fontan circulation by trying to solve the problems we can create, but we don't suggest at this point a completely new model about how to treat a single ventricle. I think that needs to wait some more innovations that I don't see them around in the very near future. Was there something else that you asked, or? What I wanted to say, though, it is kind of important not to forget the indirect benefit of having an intense study of a particular medical problem, because it's not just what you will learn that will help these patients, but may be applicable for other things. And I can tell you from my personal experience in pediatric cardiology, the concept of the single ventricle palliation, the concept of the Norwood palliation, it didn't help only the patients with hypoplastic left heart syndrome. In fact, the benefit that we got from that, it's much broader because we learned how to balance the circulation. We learned the effect of dropping the systemic vascular resistance, modifying the pulmonary vascular resistance to balance circulations in many other cardiac conditions. So there is a lot of collateral gain when you study a medical problem, not just for the single ventricle palliation. And my colleague, Dr. Flanagan, didn't mention that actually these techniques that she mentioned here, like the embolization of thoracic duct, is not only to treat the complications that we create in Fontan patients. If you have a patient with chylothorax, traumatic chylothorax, you can go actually and embolize that, and you can stop the... so there are a lot of other applications that you can use once you know the techniques and you understand what you're doing. But I'm not sure that we understand yet what we're doing. And that's why I said, although we don't have the answers, I think it's important to keep asking the questions.
At what point would you recommend that these studies be obtained? Is it after somebody's first presentation with PLE or plastic bronchitis, or after medical management has failed, or everybody X number of years after their Fontan?
Well, yeah, that's a very good question. Ideally, I would like to have the whole picture, meaning from perhaps from the time even before you get to Fontan, immediately after Fontan, and then periodically every some kind of arbitrary levels, I don't know, every couple of years, something like that. Of course, this you cannot do that if you need to have an invasive technology. And that's why I think it is important to invest in non-invasive technology. And I'm suggesting to use the ultrasound as the first screening process, and then as a second process that gradually may become much more commonplace will be the T2 weighted MRI that actually is not invasive because you get these nice images that Dr. Flanagan showed us without doing intervention. And then keep the interventions only when you start sensing a problem, either because of your screening findings or because of clinical findings. That's what I think it should be handled, but you know, we're still at the beginning of this journey. Well, I wanted to mention also a thank you to the Division of Pulmonology who has supported these challenging patients all along and also offered us their spot for presentation for greyhounds today so that they will present at a later time and I will be able to present before I leave for my next destination, which will be Atlanta from next week.
Two of these videos to work for some reason.
What some?
Switch at the top.
Okay.